Good evening and welcome to the November edition of the Best Tea Journal Club. We're fortunate this time to be joined by the team from Glasgow who are focusing on shoulder trauma for this edition and specifically the tricky beast that is proximal humeral fractures and some of the decision making about managing those fractures. Just some housekeeping. So the session is recorded and the audience will be muted, but we are very keen to hear from you and would encourage everyone to post their questions into the Q&A section Zoom, and we'll address these as talks progress. There are some audience polling opportunities, so again, participation is greatly appreciated. Everything is anonymised, and we're due to finish by 8 p.m. So the panel we've got this time round, our consultant chair is Paul Jenkins, and then we have Andrew Brooksbank, who is a consultant surgeon with them up in Glasgow, Matthew Wilson, who's their extended scope physiotherapist, and then Demetrius and Grigori, who are ST8 trainees in the west of Scotland and are presenting one of the papers each. So I'll hand over to them.
Thanks very much, Fee. It's a real honour for us to be invited from Glasgow Royal Infirmary to present to the Best Tea Journal Club, and I think it's really gone from strength to strength this year. So, just well done to the Best Tea team for getting it up off the ground. We had a bit of a theme, as you've said, for the sort of proximal humerus and what injuries that we would see commonly in fracture clinic, and a couple of really quite practical and pertinent questions. So. The format for this is we're going to spend about half an hour on each paper, with about 10 to 15 minutes for each of our sort of senior registrars to present, followed by a bit of a discussion from the piano. And as Fee said, if you have any questions, please feed them in via the Q&A, and we'll try and get through as much of them with the panel in the discussion period. So I'd like to invite Demetrius, first of all, to start to tell us about this paper, 1 versus 3 week immobilization period for non-operatively treated proximal humeral fractures. So this was an RCT that was presented in the Journal of Bone and Joint Surgery America about 3 years ago. Thanks, Demetrius.
Thank you. Can I confirm you can see my presentation?
Yep, looks good.
Perfect. Right, evening everyone. My name is Dimitris Halumas. I'm a final year trainee in the west of Scotland and an academic clinical lecturer at the University of Glasgow. Tonight I will be presenting this Spanish randomized study comparing 1 versus 3 weeks of immobilization for conservatively treated proximal humerus fractures that was published back in 2021 in JBJS. And I chose this topic, this paper rather, sorry, because the topic is very useful for daily practice for all of us, regardless of seniority, and it's also highly applicable for our physio colleagues as well. So proximal humerus fractures make up the majority of patients that we see in the shoulder fracture clinic, and the majority of them are treated non-surgically. There is no agreed consensus on the ideal length of initial immobilization. And theoretically, if you go for early immobilization, you optimize independence. However, on the other hand, if they do go for early mobilization and they have early pain, that might put them off for their rehab in general. And also, potentially, there can be more complications if you move too early. So the objectives of the study were to compare 1 versus 3 weeks of immobilization before range of movement exercises commence for just non-surgically treated fractures for pain, which was their primary outcome, as well as function, quality of life, and complications, which were all secondary objectives. And their methodology was actually pretty good overall. It was a single center, prospective randomized study. Their randomization and allocation concealment were both appropriate. Blinding was not possible given the nature of the interventions. And even though they talk about the blind assessors in the paper, as we know, for patient-reported outcome measures, the assessor is actually the patient themselves. So it wasn't really a single blinded study. For their inclusion, they had only acute fractures in adults with more than 50% bony contact from what they say and what they deemed appropriate for a non-operative management. They excluded dislocations, glenoid fractures, people who couldn't follow instructions, and those who had previous shoulder surgery. Their regime included immobilization with a sling bandage with a passive elbow range of movement starting from day one in both groups. And after immobilization, they commenced self-assisted home exercises and supervised exercises with no further details provided, but they do say the regime was the same in the two groups. They included patient-reported outcomes such as pain and the simple shoulder test, and patient and examiner outcomes, which was the constant Marley score. They conducted radiographs at 1 and 3 weeks for displacement and at 6 months for non-union. And their pre-defined complications were secondary displacement, stiffness, need for surgery, and osteonecrosis. And they followed people up for up to 2 years. Their power analysis was appropriate, and so were their statistical tests. They used an intention to treat analysis, and even though they had some minor MCID and power analysis issues, they were non-relevant given their results, so we will not be discussing those. So they randomized 67 people in the early mobilization group and 76 in the late mobilization group, and the numbers were adequate for their power analysis. Mean age was 70 years, mostly females. Their groups were comparable at baseline, which confirms that their randomization was appropriate. 7 people were treated as per the other group, and the loss to follow up was 21% at 1 year and 43% at 2 years, but we'll talk about that a bit later. They used the NEAR classification, and as we can see, the majority of them were non-displaced 2 and 3 part, but there was only one 4-part fracture. Presumably, they operated on all the other 4-part fractures. They found no statistically or clinically significant differences in any of their outcome measures, and that includes the total constant score and all its subcomponents. And there were no differences at any follow-up time points up to 2 years. Similarly, for complications, there were no differences, and the only thing that actually stood out was the incidence of secondary displacement with an odds ratio of 4.8 in the early mobilization group. That was statistically insignificant, but the number needed to harm that I calculated was 1 in 20. Now, interestingly, everyone refused, everyone who had secondary displacement refused surgery except for one patient where the displacement was picked up within the first week from what they say, and the surgeon suggested that the patient goes ahead and has surgery. So the authors, based on their results, recommend just 1 week of immobilization and quote, in order to not compromise patients' independence for an extended period. Now, in their discussion, they include a couple of older studies, and both of which found some short-term benefits with the early mobilization and similar outcomes at mid and long-term results. The strengths of the paper included its randomized nature, their appropriate and relevant outcome measures, even though if they included DASH instead of the functional scores, maybe it would have been a bit better, but constant score is still quite good. They included adequate population for their power analysis as well. On the other hand, there was no standardization for surgery versus no surgery, and they state that themselves in their limitations paragraph. Now, interestingly, they operated on about 25% of patients who presented within their recruitment period. And obviously, that's not a limitation, and we're not judging their thresholds or criteria. But it might suggest that they chose to operate on the worse fractures, and what they included in the study were the less severe ones. So things might not be as generalizable and applicable to NHS practice. The details of their rehab is not provided, that they just talk about some general principles that they use, which are quite similar to ours, but they don't talk about details of their rehab protocol. Despite the very large loss to follow up at 2 years, as they explain, all of their scores reached their maximum at about 1 year, and the 21% loss at 1 year is actually not too bad. As previously mentioned, some of their MCIDs were a bit questionable, but it wasn't really relevant based on their results. And they did not discuss the odds ratio of 4.8 for their secondary displacement in the early mobilization group at all. So one can interpret the study in two ways, really. You can say that early mobilization is better because it optimizes independence, and there are no really statistical difference in the secondary displacement or function. But at the same time, you can argue that early mobilization is probably not a good idea because you risk 1 in 20 incidence of secondary displacement. However, that might not even be clinically relevant. So we went on and conducted a meta-analysis, just trying to get some results with a stronger certainty of evidence. We found 6 eligible RCTs which compared early mobilization up to a week in a sling or late mobilization after 3 or 4 weeks in a sling. And we included outcome measures up to a year, and that was pain, function, and complications. For pain, patient-reported pain or constant score, there were no differences at any time point. However, when we combined all function instruments and used standardized mean differences, we found high certainty evidence that function was actually better in the early mobilization group at 3 months. And at 6 months, based on moderate certainty evidence, the p-value was just under clinical significance. For complications, overall complications were the same in the two groups. And secondary displacement, we found an odds ratio of 3.5 with no statistical significance, again, because of the very small numbers that we included. And that makes for a number needed to harm of 1 in 33. So in summary, there are similar long-term outcomes for pain and function if you mobilize early within a week or late at 3 to 4 weeks. There is likely better early function with early mobilization and possibly a slightly higher risk of secondary displacement. However, that's not been proven statistically and it may not even be clinically relevant. So what do I do? So at first contact, which in our unit currently is usually at 2 weeks post-injury, I prescribe some simple range of movement exercises and ask them to start as soon as possible. And I take a minute just to show them how to do pendulum exercises because I want them to at least do that until they see physio, and I refer them to physio at the same time. I explain to them that the sling, whether that's a polysling, collar and cuff or equivalent, is purely for their comfort. And I usually give them a rough timeline about what to expect in terms of how long they will need it most of the day, then progress to potentially wear it outside, when to take it off for sleep and so on. And I focus on good analgesia, and especially before they actually carry out their exercises, just to optimize things as much as possible. For the future, I think we should potentially try and identify particular fracture patterns that may benefit from longer immobilization, if there are any, potentially um, fracture dislocations, for example. We also need to know whether home or supervised, sorry, whether home physio is as good as supervised physio, and there is some evidence to suggest that they are as good. However, there may be patient groups who would potentially benefit from supervised physio a bit more. We should be a bit more confident with lifting and especially weight bearing restrictions when it comes to weight bearing through gutter frames, Zimmer frames, and so on. And we still are not confident if there is a best type of sling and whether particular types are better for particular fracture patterns and so on. Thank you very much, and I'll be happy to take questions, and I'm looking forward to your thoughts.
But thanks very much, Demetrius. No, that was really interesting. Um, I just wanted to ask about, because obviously this issue of the secondary displacement comes up, and I think probably in our minds that's what we're particularly sort of concerned about. And then we have the tension between what we see as the patient-reported outcomes, the constant score, which is a bit of a mixture of a problem with some objective findings.
Mhm.
But the secondary displacement, I suppose, in all these things, although there's an odds ratio of, it was 4.8 here, potentially in other studies, somewhere around two, the confidence intervals for those odds ratios tend to cross one. And in that case, if you were calculating a number needed to treat, should that also have a confidence interval around it? Because that
Yeah.
may well vary from, several hundred to
Mhm.
a lower number.
Yeah, no, you're right. Because the incidence is so low, we in the analysis we are dealing with very small numbers, and that's why obviously confidence intervals are so wide, and statistical significance is not reached. But an odds ratio of 4.8, if it extrapolates to larger populations, it's a significant one, and the number needed to harm of 1 in 20 is something to definitely consider. But the fact that 4 out of 5 of their patients didn't even go ahead to have surgery when they displaced secondarily might suggest that it might not even clinically relevant anyway.
And I suppose also because we do know that there is a poor correlation between radiological outcome and clinical outcome. Um, I just wanted to bring in my colleague Andy Brooksbank at this point. Andy, one thing I noticed was the like 15% in this study were sort of GT fractures or the two-part fracture. Do you have a different sort of leveling of anxiety or protocol if you're seeing these patients with
Yeah,
immobilization?
yeah, I think Demetrius mentioned it actually. That certainly, people with a fracture dislocation, you'd certainly be more concerned about further displacement with those cases, particularly because the soft tissue injury is more extensive. The other type of fractures that we tend to worry about is where there's lack of medial support that might tip into varus. Would be I guess those would be the two things that would come to mind. So we would probably tend to be more cautious, possibly in the younger patients, and high energy trauma, from the point of view of potential for displacement. But because the numbers are, there's at times we are guessing, I guess, from the point of view of the prediction. One of the things that I think was interesting is just on a practical basis. A lot of studies that I've read about immobilization have really concentrated on the instigation of the physiotherapy treatment at various time points. But the impression I got from this paper that they were actually taking the slings off people and discarding with that aspect plus the therapy, because there's a subtle difference between the two, between keeping somebody with, for instance, a sling for comfort, but instigating their exercise program. I don't know what Demetrius, what impression you got from this, and maybe we could
I
bring
mean,
Matt as
yeah,
well.
it's a good point. It's quite difficult to make definitive conclusions about their exact regime because they just don't provide very much information at all. And this is primarily a physio paper that mostly talks about exercise, and they don't even provide details about their exercise regime, which is quite important. It's good enough, I guess, for the purposes of the study that the regime was the same in the two groups, but it would have been a lot more useful for us physios to know exactly what their regime was. But you're right, it's unclear exactly what instructions they gave patients about slings and how long to keep them on and so on.
Because I think at a week remove, if you take this a sling off a patient in the clinic, when you know how sore people can be at a week post proximal humerus fracture, then there'll be, I suspect, there will be a bit of pushback from the patients.
Yeah.
Yeah, absolutely. My thought on it is you need to standardize depending on the type of fracture. So if you've got a greater tuberosity fracture and you've got someone doing active elevation very early on, that'll risk kefalad kind of migration of it, as opposed to a different type of fracture where that's not as much of an issue. So it could have conflated the outcomes, so yeah, you really need more information on the actual type of exercise they give, because I know we certainly only do kind of passive elevation type stuff, table walk backs, active assisted maybe at 4 weeks depending on pain, but active stuff is way down the track. So yeah, it's hard to really conclude with their findings.
I wanted to ask Matt, because obviously you work with us in the fracture clinic, but you've also seen the other side of it from the more sort of MSK physio sort of side of it, and in terms of where you sort of feel patients are with mobilization, sling removal after these injuries. What's your experience been?
I would say it's twofold, really. I would say patients are very hesitant to remove them in spite of the advice to get rid of them, because a fracture and only wearing something for 2 or 3 weeks seems a bit counterintuitive to them. And also, physiotherapists on the whole are quite cautious with this kind of thing, as you see it with other accelerated programs like such as meniscal repairs, ACL. A lot of the literature is moving towards doing things a lot more quickly, and it's at odds with what we were taught at university, or kind of archaic beliefs, I suppose. But pain's the main limiting factor with rehab with this stuff, not optimizing analgesia, as Demetrius was saying. Patients really struggle to progress in those early days. Whereas things in supine, using like the table a lot, and supported exercise, early mobilization, I'd be behind. More active stuff, I just don't think the patient could do it personally. But
Yeah, I just going back to, I suppose if I think back to probably 19, 20 years ago when I started, I was trying to looking at this particular question, and the group in Sheffield at the time, David Stanley, produced a paper on a very similar topic, and I don't know if that came up in the papers you looked at, Demetrius, but their paper at the time talked about having a stable fracture and mobilizing what they determined as a stable fracture early at the sort of, and again it was around the week to 10 days, and from a practical perspective, if you've got a patient and you can passively move them, and they feel that the fracture is not particularly mobile, I think that's certainly the patient that will find that early mobilization easier and more tolerable from a pain perspective. And I guess this very group that they've picked are probably going to be more of those fractures with less displacement and more of a stable configuration that will stabilize early with some early callus formation within that sort of first week.
I think that's a good point. You're right. They are self-selecting. Fee, I see there's a question come in, which
Yes.
I find this one fascinating. So I'd be interested to see Matt's thoughts on it. Do you
Yeah,
want
so
to
a
read it out?
question that just is querying, does the team think that pendular exercises, essentially an open chain exercise, is the best advice? And should closed chain movements not be suggested first?
yeah, pendulum it's interesting, especially one for what the patient takes away as pendulum. It's meant to be, utilizing momentum and very much a passive exercise. But when you see patients and what they're doing, it's they're throwing their arm around in a circle, bent over, a lot of the time. And yeah, I completely agree. The main thing I give early on is table walkbacks. So their arm is completely deloaded, and also supine passive stuff. Because again, it's just taking that element of gravity and traction of the limb out of it. If you think of the tensile force that would be on the fracture from hanging the limb, um, again, I agree with Mr. Brooksbank in the sense of patients. Some patients progress really quickly, and I would assume that's your stable fracture, and you can kind of pursue more aggressive exercise and just trust that the body will tell them if they shouldn't. Um, but yeah, that's a good question around the pendulum. Naturally, I try and avoid. Well, I don't tend to prescribe it all that much. I stick to supine stuff and table walkbacks just because of the variability and how patients take heed of that information.
I'm feeling we're going to have to go into fracture clinic tomorrow and remove all our pendular leaflets.
Well, yeah, I mean, there's been a lot of work done on EMGs and pendular exercises that's shown fairly high levels of cuff activation over more purely passive, and certainly I think as you say the table step backs are a good adjunct, and we've changed our protocol several years ago to add those in for sure.
Can I?
There's another question that's just popped up here as well. It's just kind of related, asking what are thoughts about patient-led mobilization, i.e., that the patient removes the sling when they feel able to, rather than being too prescriptive.
It's an interesting one because my fear in this is that you then will find the patient who comes back at 6 weeks and 3 months still wearing a sling, and they you I've had it myself. They've seen me the previous time. I've gone through all of this. I've said, get this off as soon as you can. And then they've gone away with a completely different sort of message. And unless you put the sling in the bin for that patient, they will just keep on wearing it forever.
Yeah, I think it's an error that it goes one way and not the other, and I think the self-selecting patient who removes the sling earlier probably have got a pretty stable fracture, and it's not too sore. But I think the danger is it's the flip side the other way, and you do occasionally get the people who turn up with they've been in a sling for 3 months, and so it's not going to go well from a stiffness perspective.
Andy, I just have a quick question to ask you guys in Glasgow. On a more pragmatic level, maybe not specific to this paper, we talked about the secondary displacement and fractures like the tuberosity or the posteriorly displaced tuberosities, which is an unstable configuration. Do you change your practice with what kind of a sling you give them? For example, is there a choice for I don't know, like a neutral sling or a splint that prevents the internal rotated position of the arm, or do you just give
Yeah,
them?
I mean they're issued with a kind of polysling from the emergency department, and yeah, I have to say, I suppose I looked at this a few years ago and came to the conclusion that irrespective of the type of slings, it didn't seem to make a difference, and that was the literature at the time. So yeah, we might change to a collar and cuff occasionally, and that's often can be body habitus or just to make it easy for the patients. But yeah, I'm not we're not trying to manipulate the fracture position through the position of the arm generally.
Sure, thanks.
And there's one last question, which is, I guess, is similar, but I've heard conflicting opinions regarding GT fracture involvement and conservative treatment. I'd be interested to hear the panelists' protocols and thoughts around that.
Yeah, I mean our kind of protocols for the fractures that come, most people will come between the week to 2 week mark from the virtual clinic. They will generally pretty much, we will, apart from somebody who is the kind of super elderly category, we will generally re-x-ray people at that visit. And I suppose the group that we may choose to see again, say a week later, may be the people we predict or think might have high risk. And in relation to GT fractures, that'd be people who are associated with a dislocation.
Thanks very much, Andy. I think we'll move on to paper two. That's been a really interesting discussion we've had on that first paper. So thank you, Demetris, and for the panel and the questions that we've had from the attendees. Grigori is going to take us through the second paper, which I didn't realize when we picked these papers, but they've got a Spanish theme. Both are from Spanish units, but this was in GSES and it's reverse shoulder arthroplasty or nothing for patients with displaced proximal humeral fractures and RCT. And I think this was what year was this? 2024. So
It was
it's
earlier this year.
bang up to date.
Yes. Thank you, Mr. Jenkinson. Thank you, Bez, for asking me to present this paper. And I don't think I can do this any justice without going through a bit of background about proximal humerus fracture. And there's a bit of a poll to break the lull of the middle of the session. So first, conflict of interest. I'm an orthopedic trainee and I like to operate. So, but apart from that, there are none. So we're going to start with the poll and I'm going to really try to make this work, which may not happen. So we will try this. And so if this is so question one, this is your 21-year-old female who has a fall from 2-story and they have no past medical history and they have this proximal humerus fracture. It's closed, it's neurovascularly intact. So I'm going to start this poll. Is that working at all? Right. Let's see if that works. So we're going to spend very little time. So just what do you think you want to do with this patient? Okay, so that's exactly what. Okay, so one person, three people, non-operative management. Okay, great. So I'm going to end the poll. So, and then we're going to share the results so you can all have a look. Okay. So 90% would want to fix this fracture, which is what I would predict. Okay, I'll stop sharing and then, oh dear, I think I've done something bad. Right, so we're going to go to question 2. Now, this is a 70-year-old female who's fallen from standing. They've got a background of hypertension, otherwise quite well, plays golf. What are we going for? We'll give it 30 seconds. And poll, and we're going to share the results. And as expected, there's a lot of differences amongst opinions about this particular patient. And we're going to move to question 3, which is exactly the same x-ray and a 70-year-old female who falls from standing but has a background of vascular dementia, has had previous CVA. Hang on a moment, I've clearly got myself stuck with the last one. Here we go. So what do we, and she's a nursing home resident, so how are we treating her? Okay. That is pretty unanimous. Okay, so, and as expected, the most dubiety lies with how we're going to treat that 70-year-old lady who's well and what operative treatment are we going to give her. So so moving forward, bit of background about everything in proximal humerus fracture really. So can't really go far without describing NAERS classification, as most of proximal humerus fracture literature seems to focus on NAERS classification system. There's one or two which describes a classification, but majority focus on how NAER described them. But actually NAERS classification, if we have a look through it, described the fracture, the mechanism of injury, the level of the fractures, but did not really go into the surgical relevance of the displaced tuberosity. And over time, we have also noted that there is a low inter-observer reliability and intra-observer reproducibility. And based on Neer's classification, fracture dislocations he felt would have the highest risk of avascular necrosis. But actually 38 years later, Hertel identified that the most important predictor of ischemia was actually the integrity of the medial hinge and also the length of the posteromedial calcar hinge of greater than or rather less than 8 millimeters predicted risk of poor perfusion, but not necessarily avascular necrosis. And Margaret McQueen in 2001 also identified that it's actually the elderly patients who are more likely to have a more complex fracture. If you look at the fracture dislocation group, yes, 5% of 59-year-old may have a fracture dislocation, but if you look at the 73-year-olds, the fracture pattern is far more concerning and therefore likely to do poorly. So what does the epidemiology of proximal humerus fracture tell us? Well, this particular paper from Peretti explains that not only is proximal humerus fractures more prevalent, but actually mortality from these fractures is also very high. And similarly, the Swedish registry study identified that the 1-year mortality following this injury is approximately 7.83%. Now, that is, you say, well, actually hip fracture mortality is much higher, which is of course true, but this is not insignificant. So moving forward, we cannot really talk about proximal humerus fractures without talking about the best set of data that, well, the most relevant study that we always look at with regards to proximal humerus fracture treatment, and that is the PROFA randomized control trial. But what was interesting is in this large UK study, there was no statistically or clinical significant difference between the surgical and the non-surgical treatment plan. But looking at the type of surgery offered in this study, there is no reverse shoulder arthroplasty that was included. And so at the same time as PROFA was ongoing and data was being collected, there were multiple other studies that occurred. So Navarro in the States recognized that hemiarthroplasties and open reduction internal fixations were actually happening less and less, but what was happening more and more is reverse shoulder arthroplasty for proximal humerus fractures, and it went from 4.5% to 67.4% in all arthroplasties in 2016. And similarly, in this paper also recognized that in the over 65s, reverse shoulder replacements had also increased significantly to 24.5%. And in the States, this was between New Orleans and California, reverse shoulder arthroplasty increased by 1,841%. But you say, well, is it because they were operating more? Well, actually not, because their non-operative group was also approximately 89%. So 89% of their patients were having non-operative management, but of the ones that were having reverse shoulder arthroplasty, it was 18, that percentage had increased significantly. So yes, we were doing more of these, but is it the right operation? So what multiple papers recognized was, yes, in very small numbers, it did show an improved function, an improved pain score in the short term. However, further high quality trials should be done for the reverse shoulder arthroplasty groups to recognize its full effect. And very similarly, superior outcomes with reverse shoulder arthroplasties versus non-operative management in a matched cohort analysis demonstrated improved outcomes. But again, it wasn't clinically significant. Going through further data, it seems to have a trend. It shows that reverse arthroplasty should only be proposed in patients with a significant functional demand and minimal benefit over non-operative treatment. So where are we now? Well, this particular paper is looking to, well, we should probably focus on the paper that we're going to talk about. We've talked about a lot of the background evidence, but this particular paper had one clinical question. We have all this evidence, but is it truly a better treatment plan and treatment option compared to non-operative treatment? And we're only focusing on those that are over 65 because we know what we're going to do for the young, fit patient who has a proximal humerus fracture. So going a little bit through the study design. So it was a multi-center randomized control trial. It was multi-center. It was based in one city. It was in Madrid. This was in Barcelona, not Madrid, which is the other randomized control trial. They collected data between October 2015 and ended in July 2021. The radiological inclusion criteria, or rather exclusion criteria, so they excluded everyone who had a glenohumeral dislocation, a head split fracture, and they felt that the shaft had completely displaced from the humeral head. Their methodology, they generated a randomization of 1-to-1. The participants were informed of their treatment allocation once they were enrolled in the study. Of the 37 participants who were allocated the surgical treatment group, 2 ended up declining surgical intervention. However, they were kept within the surgical group for further analysis. In this group, the approximately loss to follow-up ratio was 16.22%. 44 participants were in the non-operative treatment arm, and 9 or 20.45% were lost to follow-up. So on a technical note, they reattached tuberosities in the operative group, and also their post-op regime was pretty much similar to what the non-operative group received, which was 3 weeks in sling with progressive passive range of movement for the first 6 weeks, an active range of motion from 6 weeks onwards, and strengthening from week 12. Interestingly, I'm not sure if this was intended or there was but essentially the operative treatment group, there was only 35 who had the operation. But if you look at how many received a glenoid implant, there was 25 medialized and 12 lateralized, which doesn't quite add up to the number 35. But that may be because it was the intention to treat rather than those truly treated. So moving on with the results. So as you can see, most of the 4-part fractures, 59% were in the surgical treatment group, which, although this is randomized, there may be a surgical bias, but there is no way of gleaning that from the study or looking through the discussions or the results. And more 3-part fractures were proportionately treated non-operatively. So there is a significant difference in or what they describe as a significant difference in the constant Murley score at 1 year follow-up. Now, interestingly, they did not continue the follow-up for greater than 1 year because they felt that they would have significant loss to follow-up, and their power analysis calculations would result their study non-statistically significant. So there were specific differences that they found were the daily life activities in forward elevation and abduction. And that is similar to all the other randomized, or the only one other randomized control trial. And they also identified that those were the similar differences that could be identified between the surgical and the non-surgical group. There's also a wide confidence interval, which therefore suggests that it may be that the true value lies somewhere in between and therefore is probably not statistically significant. The MCID score for a reverse shoulder arthroplasty is usually 10 points for the CMS, but the point estimate difference for this particular study is 8.84, and therefore it may be it would suggest that this is not, the difference seen is not clinically relevant. In the operative treatment arm, there were also two complications, one being a periprosthetic fracture and the other a axillary nerve palsy, which had not recovered at the 1-year follow-up. So what can we conclude? So from this study, we conclude that patients over 70-year-old may benefit from surgical treatment with the reverse shoulder arthroplasty, and those benefits are particularly in their function and activities of daily living. Surgery may be indicated with caution. The outcomes differences between the non-operative treatment are small, and of course the risk of complications is higher. So do we think this paper has answered the question that we asked at the beginning? So their question was that all the present study wanted to explore the benefits of surgical treatment, considering the implantation of a total shoulder arthroplasty over non-operative treatment. So looking through this and looking through literature, I'm not sure this study has helped us conclude one way or another. It has added to, or further added to, the body of evidence that we already have. Looking through the background of the literature and what was quoted in this paper, what was really interesting is what we do know, or what we can tell, is reverse shoulder arthroplasty is superior to plate fixation at 2 years for displaced proximal humerus fracture. But also, interestingly, there's a commentary in the Bone and Joint Surgery America, which says a word of caution regarding these being treated with the reverse. But it talks about longevity of implants and the risk of revision, whereas most of the implants we use today have a 10A ODEP rating. So is that truly a problem? So that's one question. What we also know is reverse shoulder arthroplasty compared to hemiarthroplasty in displaced 3 or 4 part fractures in patients over 65 have a better functional outcome. And also, acute intervention is better than delayed reverse shoulder arthroplasty in the fracture setting, because delay in performing may come at a cost of worse functional outcome. And also, tuberosity healing gives the patients improved forward elevation and also external rotation and an overall improved shoulder function. So what can we recommend from this body of information that we have about reverse shoulder arthroplasties in fracture? Well, it remains a valid option for patients in the over 65s. And it is very important, and as we all know, when we consent patients for operative management, that we need to evaluate and counsel our patients. And one thing that I did not come across through looking through a lot of this literature is we do not consider what the patient, often in research, maybe it is, what their pre-injury functional status is truly. We should always consider non-operative treatment and consider early reverse if it's appropriate, and also consider reattaching the tuberosities. So Neer in 1970s demonstrated that 90% of his patients who received a arthroplasty for a 4-part fracture had a good functional outcome. We're yet to find yet to find any evidence to match that data. So what do we need? There is a need for a large multi-center retrospective RCT to define the role of reverse shoulder arthroplasty, particularly in the complex elderly proximal humerus fracture. Which hopefully brings us to Profit 2, which is currently finished recruiting, I should say, and we are going to hopefully have some results in another year's time, so November 25, because they have a 2-year follow-up comparing all the three groups that, and hopefully that will help us answer some of the questions that rise from in our treatment or discussing treatment options for our patients who are over 65 with the proximal humerus fracture. Thank you.
Thanks very much, Grigori. In terms of, but both of these studies actually interestingly used the constant score, which I think in the more recent literature we haven't sort of seen quite so much of. Did you have any sort of thoughts about that in itself, or any issues that may have come up from that?
So I think the constant scores, from what I could understand in particularly this study, they focused on they used a goniometer and various dynamic methods to evaluate the range of motion for the patients. So I think they used a digital goniometer to work out their range of motion. I think they used a digital dynamometer to analyze the strength. But what the study did say was in its discussion that they probably should have used a DASH score or some sort of functional, a patient-related outcome measure, because that would be better for understanding if or add to their evidence that functional outcome would be better rather than using the CMS score.
And did you come across, I was just trying to look through, did they do any form of like subgroup analysis to try to work out, like in the, in the non-operative group, which patients were responsible for that, those poorer outcomes at the lower end of that graph?
I did not find any significant subgroup analysis. I think that from my recollection of the paper, but what they mostly focused on was they subdivided each group into good outcome, excellent outcome, and poor outcome, but there wasn't any specific subgroup analysis that I came across.
I think, an interesting figure which came out, and I suppose it's a bit along the lines of what Dimitris was talking about in the first paper. They've reported that sort of the number needed to treat was sort of between 2.5 and 3 to be treated by reversed, prevent, or to convert one patient into a good to excellent outcome on the constant score, which is favorable compared to other studies we've looked at.
So I think the fragility index on this one was 5 participants because they said that if 5 participants from the operative group changed into poor, that would render that'll destroy any of the clinical significance that was demonstrated by the study.
I think, can I bring in Andy, and then I think we've got a question from the team online.
Yeah, I did notice in there they had early dementia as a subgroup, and I think they had an even split of maybe a few patients in each arm. And I don't know what the rest of the panel feels, but certainly I think that the study from the population study that looked at the 7.8% mortality, 1 year mortality rate, I think it is quite, that is something really to pay attention to. And then if we add in sort of frailty index and how we look at patients in the fracture clinic, and it can be difficult sometimes to fully assess somebody's competence in that snapshot you have in a busy fracture clinic. But I think that's definitely an important subgroup that we should give as much attention to as possible when we're thinking about the risks of arthroplasty. So I think, going down to sort of patient selection, I think it adds a little bit of weight towards that in the right patient, a reverse may have some benefit. Because I can remember the numbers needed to treat that we came up with in our clavicle study. I think I think Paul, it was probably about 6 patients, wasn't it, to prevent one non-union of a clavicle by fixing clavicles. I think there's definitely it definitely adds some weight to our body of evidence at the minute.
Yeah.
But again, this thing about the outcome measures as well, we've got so many different studies with so many using different outcome measures, whether it's simple shoulder test, the Oxford scores, or constant scores, or American shoulder and elbow scores. It does make it difficult to really decide what is a true clinical difference for the outcomes. But certainly caution over your patient consideration and selection, I would say.
Thanks very much. And do you want to go to the question, Fee?
Yeah, so just one question. Confidence intervals in reverse arthroplasty are visibly less than the non-operative group, indicating a potentially more consistent result with reverse arthroplasty. So does this help support the use of reverse arthroplasty, and is it important information for the patient? Is there agreement on that?
Yes, I do think this is important information. I think you can look at a fracture and say actually the range of outcome could be from poor to good, and this does provide a more consistent outcome, and that's certainly our findings. But it does rely again on sort of patient selection, and you can even try and improve those outcomes further by trying to avoid operating those with higher predictors of bad outcome, whatever you do to them. I suppose bringing you in, sort of Matt, in terms of the experience of reverse in both the sort of fracture clinic and subsequently from a rehab point of view, what was your sort of impression of this group of patients?
Yeah, they done well. When I first came through in rehab, the kind of belief was you're lucky if you get 100 degrees with a reverse and so on. But then as time has gone on, whether it's technique or prosthetics or whatever, a full range, good functional outcome can be seen. And some of them improve really quickly, whereas some RFs that have seen non-operatives, it's varied across the board. So it kind of fits with the debate in the literature. There's no real agreement yet. So, but yeah, varied experience.
And it's sort of the direction we're going in with the other end of the sort of humorous, in terms of we're looking at approaches and operations which tend to lead to more of a sort of consistency of outcome rather than the sort of wider variation we tend to see. Demetrius, any thoughts from you on this paper?
I think it's quite important when it comes to these studies and our outcomes in general to not forget that early results are quite important for the patient. It's not just good enough for us to say at 1 or 2 years down the line, the outcomes are the same. If there is a significant difference at 3 months down the line, 6 months down the line, and we certainly see at least clinically, a lot better range of movement, better function in the reverse group compared to the conservatively managed group, which takes a bit longer to get better. That's still a year or two of the patient's life. And, we're talking about elderly patients there. They need their independence. So 1 or 2 year outcomes are not good enough. We do need to pay a bit more attention, I think, to the earlier outcomes.
That's a really important point, and I think you're right. When we see these people at 6 weeks and 3 months, these are important times. And when we look to the study design and the sort of randomized pragmatic trials with the assessments at that time period, hopefully that's what we'll sort of look towards, a bit more granular data coming from the likes of sort of Prof2, as you said. Grigori. I don't see any more sort of questions coming through now. I don't know. Do you want to sort of sum up any final thoughts, Grigori, from this paper?
So I think it's as the panel has already mentioned. I think it all boils down to patient selection, and also really important to focus on the patient's pre-morbid or pre-injury function, because ultimately most of our patients, that's what they're looking for. And as Dimitri rightly pointed out, what they want to go back to is at least that in the well, of course, less than what it was. But if they're pain free and they have a good early range of movement, I think they are happy. But yes, we do not know what the true outcome will be going forward. But we also have the age the age of the patient means that they do have a high mortality associated with them. But should we give them a better functioning shoulder that they can do their things, do whatever they want to do with for the short time?
There's a question has snuck in just at the end here.
So final question, higher rates of shoulder prosthetic joint infection in males, should gender play a role in considering non-surgical versus any arthroplasty in this patient group?
Maybe give that to Andy.
Yeah, it's a good. I think it's a good. It's a good question, and I think some of the repair. I think there's one of the Scandinavian papers or joint registries had a fairly alarming rate of or an alarming difference in infection rates in males versus females. I can't. I'll have to go back and look at the paper, but certainly majority of our fragility fractures will be female dominant from the point of view of the age, and I guess it's probably a 70-30 split. So, to be honest, I don't necessarily take that into a consideration at the time. I think looking at the global health of the patient is important, but I wouldn't. I don't think I've ever sat there and thought I'm not going to do something on the basis of whether they're female or male. I think cognizant of potential infection risk, I'm not sure we've necessarily seen such a big difference in our own practice in Glasgow over the last 20 years. But clearly, obviously, registered data has a lot more power than individual observation. So I think it's definitely something to consider, but I think you've got to really take each case on face value.
I was just also going to add, and I'm sure you guys will correct me, but the male patients who do have proximal humerus fracture also tend to be more comorbid compared to the females, according to some of the epidemiological studies that I looked at. So it may be that it has a role to play. I do not know if that study was matched to the individual patient comorbidities or not.
I think it was arthroplasty, reverse arthroplasty in general, rather than specifically fractures.
Sure.
So thanks very much. Thanks everybody very much. I think that's us from the Glasgow team and these couple of papers. So thanks for your time today. I'd like to thank all my colleagues on the panel as well for the time, and we'll hand back to Fee to sum up for the session.
Yeah, so I'd just like to echo thanks to the panel, to the speakers who have taken the time to prepare so thoroughly, and to everyone who supported online with questions and interacting with the poll. You'll all get your certificates of attendance, which will follow in the next week or so. This first 2024 programme was a bit of a voyage of discovery in terms of the Journal Club, but I think the consensus is that it will continue. And the programme for 2025 is just being finalised, so we'll get that put up online and publicised so that you can sign up and get the dates in your diary for the next year. Equally, if you are in a unit and you would like to be involved as a host unit, we're always looking and collecting a list of units to approach. So feel free to email us on the education account just detailed there, and we can slot you into the programme over the next year or so. Equally, I'm probably preaching to the converted because you're already here, but for anyone that's relevant, signing up to Best T will keep you included on any emails and newsletters. We're in the process of handing over from myself to the incoming trainee rep, and I think there's a plan to kind of renew what direction Best T takes and where our efforts are best invested. So if you're on the mailing list, then we can include your thoughts on that. And that's all I have to say, really. So thank you and good night. Enjoy the rest of your evening.
Great. Thanks, Fee.